Dr. Chatterjee, I'll turn it over to you.
Thank you, Christina. Good afternoon to you all. Thank you very much for joining us today on this very important discussion of Hispanic and Latinx health issues and disparities in the United States. I want to congratulate the Office of Diversity, of Excellence in Diversity and Inclusion on putting together this session today, particularly Dr. Hector Rasgado Flores, who has taken the lead in developing the panel discussion. My thanks to all of the panelists as well for providing your time and expertise to us as we all learn about these very important issues. This is particularly important as we celebrate Hispanic Heritage Month, and this is part of those celebrations. So thank you very much.
Thank you, Dean Chatterjee. We are very pleased. We are thrilled to present to you today's presentation. It's entitled Hispanic Latinx Health Issues and Disparities in the United States. We are very fortunate to have three extraordinary presenters. Dr. John Paul Sanchez, whose title of his presentation is Update on Hispanic Health Issues and Disparities in the U.S. Captain Dr. Kenneth Dominguez, whose presentation title is Leading Causes of Death, Prevalence of Disease and Risk Factors and Use of Health Services among Hispanics in the U.S. And Dr. Francisco Moreno, whose title of the presentation is Latinx Mental Health Considerations. We will also have a testimonial from a Latinx Hispanic patient, Michael Story, and we'll have a few minutes to have questions and answers. Our three presenters, whose biographies I will briefly read in a moment, are going to make a joint presentation, although they have separate sets of slides. That will take about 30 minutes. Then we'll have a few minutes for the patient testimonial, and the remaining of the time we will use for question and answers. Let me start by introducing Dr. John Paul Sanchez. He is a professor and vice chair of Diversity, Equity, and Inclusion, Emergency Medicine, Fellowship Director of the Learning Environment Office at University of New Mexico School of Medicine. He's also the senior advisor to the vice chancellor and the board member of the Journal of Academic Medicine. He is the associate editor of MedEd Portal and executive director of the Latino Medical Student Association, which is the largest student association in the country with 130 chapters at medical school across the country. The largest student association for Latin Hispanic students. He received his medical degree from Albert Einstein College of Medicine and is board certified in emergency medicine. He has a master's in public health with a concentration in epidemiology from Yale University. Captain Kenneth Dominguez, he received his training from Harvard University and Columbia University. He's trained in Epidemic Intelligence Service Officer by the Center for Disease Control. He is an active participant in the Center for Disease Control COVID-19 response as it relates to screening of travelers, monitoring and assessment for the Center for Deployer symptoms. He focuses on the area of biomedical interventions to prevent HIV transmission, and he's co-project officer of the TRIBE, which is a program to increase the access to HIV prevention. He's also an advisory committee member of the Anti-Retroviral Pregnancy Register for congenital birth defects. He has served for the Central Disease Control spokesman for several HIV prevention social media campaigns, and he's co-author of the Central Disease Control first vital study describing the health status of Hispanics in the United States. And finally, Dr. Francisco Moreno is a professor of psychiatry at the University of Arizona Colleges of Medicine, and he's the vice president of the University of Arizona Health Science Office of Diversity and Inclusion. He's the principal investigator and engagement lead for the NIH Precision Medicine Initiative Program and of the Arizona Hope Project, which is a program which works to enhance diversity for the health professional work. He has been conducting research in the biology and treatment of mood and anxiety disorders geared to improve our understanding of the brain basis for mental illness. He has created and supports programs to improve the mental health services for Hispanic immigrants and other disadvantaged communities in Arizona. So as you see, we are incredibly fortunate to have this very distinguished panel group. And so now I will ask Dr. Jean-Paul Sanchez to start his presentation.
So good afternoon, everyone. It's truly a pleasure to be joining you as we come to sort of the end of Hispanic Heritage Month, but also recognize that discussing the issues and disparities of the Hispanic community is an everyday need. Let me start off by thanking Dean Chatterjee for supporting this initiative and for the diversity work at the institution. Thank you to Dr. Hector Rascado Flores, who I've worked with for the past couple of years and recently was elected and selected to be a part of the executive committee for the Latino Medical Student Association. His perspective is extremely important in helping the organization succeed on the local, regional, and national level. So thank you again, Dr. Rascado Flores, for everything you do. And thank you, Cristina Rontel, for helping us make this a reality as well. So I'm just going to be covering a couple of slides to contextualize today's discussion and really highlight some of the social determinants that play a role in affecting the unique health issues and disparities of the community. The learning objectives for today's session is to describe the Hispanic, Latina, Latino, Latinx representation in the US. And there's many other terms that the community uses as self-affirmation and self-identity, including terms unique to their national origin. So both of my parents were born in Puerto Rico and I identify as Puerto Rican. Dr. Dominguez will be highlighting some of the main findings from a report that he led, the CDC Hispanic Health Vital Signs Report. And then Dr. Moreno will be reviewing common psychological and psychiatric conditions affecting the community, as well as highlighting the impact of COVID-19 on the well-being of our community. As we know that Hispanics, African Americans, and indigenous populations have faced an increased burden of this condition. So the following stats and facts that I'm going to be sharing with you were derived from the Pew Research Center. So if you wanted to just follow up after this, that is a great source of information. But the take home of this slide is to know that there are over 60 million individuals who reside in the United States who are part of the community that we'll be talking about today. And I use Hispanic as an umbrella term. However, realize that there's many terms associated with our community. By far, the largest community within the Hispanic community of a nationality is those individuals from Mexico or of Mexican heritage, 62%. And the Mexican, Chicano, Chicana community is followed by Puerto Ricans, Salvadorians, Cubans, and Dominicans, each at 4%. But as you can see here within the United States, we have great diversity representing all of the countries of Latin America, South and Central America, as well as the Caribbean. And it's important to realize the subtle linguistic and other cultural differences between these groups. So just to share some other facts about the Hispanic population, when we consider which subgroups are the fastest growing population, it's those of Venezuela, the Dominican Republic, and Guatemala. The subset who identify as immigrants have decreased between 2017 and 2010. However, they still represent Hispanic immigrants, are 1/3 of the Hispanic population. And the vast majority of Latinos or Hispanics are US citizens. In 2017, that was 70%. There is an increasing share of Hispanic Latinos who speak English proficiently. And in 2017, 70% of Latinos age 5 or older were proficient in English. The Hispanic representation is not only in urban environments, but also in rural areas across the country. And the median age of US Hispanics and Latinos has increased since 2010. In 2017, it was 29. Of all of the Hispanic subgroups, those of Venezuelan origin have the highest share of a bachelor degree, approximately about 55%. And that might be tied to the recent economic and political situation in the country of Venezuela and individuals fleeing for additional opportunities here in the US. And then lastly is just giving you some information about the economic conditions of Latinos. Those individuals who trace their heritage to Argentina had the highest median household income at about $68,000. However, that is about $20,000 more than the overall Latino median at $49,000. So there is much variety and diversity in terms of economic conditions within the Hispanic population. And with that, now I'm going to hand it over to Dr. Dominguez to share some additional information. Thank you.
Great. Is everyone able to see my slides? Yes. Can everyone hear me?
Yes, Doctor.
Okay, great. So I'd like to start off the presentation, first of all, by saying thank you to Dean Chatterjee, also to Dr. Rasgado Flores, Cristina Prontel, and the LMSA chapter for inviting CDC to participate in today's presentation. Some introductory comments. Hispanics are estimated to represent about 1 in 6 people and estimated to go to as many as 1 in 4 people in 2035. It's the largest racial ethnic minority population. Currently, there's a NIH study called the Hispanic Community Health Study in 4 cities that has shown key differences by Hispanic origin and other factors. But in terms of published national health estimates by Hispanic origin and nativity, these are quite lacking. And so that was one of the reasons why we decided to do this particular study. So the purpose of this particular study was to provide a nationally representative study of causes of death, prevalence of disease and risk factors, and use of health services. In terms of our methods, we compared Hispanics, Hispanic subgroups, and non-Hispanic whites by nativity and sex where possible, focusing on the age group of 18 to 65. And during the years of 2009 to 2013, we used the following data sources. For socio-demographics, we used the American Community Survey, leading causes of death, the National Vital Statistics System, disease prevalence and risk factors. We use both the National Health Interview Survey and National Health Examination and Nutrition Survey. And for use of health services, we looked at National Health Interview Survey. So in summary, in terms of the demographics, we saw that together, Mexicans, Puerto Ricans, and Central Americans represented about a little more than 8 in every 10 Latinos in the US. About 1/3 had not completed high school, compared to about 1 in 10 in non-Hispanic whites. About 1 in 4 lives below the poverty line compared to about 1 in 10 among non-Hispanic whites. And about 1 in 3 does not speak English well compared to 2 in 100 among non-Hispanic whites. And just to show you some of the diversity among the Hispanic subgroups, we can see the median age of Hispanic whites, 42.8 versus Hispanic Latinos at 28. But you can see there's quite a wide range. Mexicans at 26.2 and Cubans as high as 40.6 on average. In terms of percentage with less than a high school diploma, non-Hispanic whites at 8.3, whereas Hispanic Latinos were at 35.3, and a range of 44.9 for Central Americans to a low of 14.3% among South Americans. So quite a range there. Also, percent who speak English less than very well, 1.6 of non-Hispanic whites versus 32.3 of Hispanic Latinos, and a range of 48.7 on the high end for Central Americans, and Puerto Ricans a low of 17.4%. Percent living below the poverty line, non-Hispanic whites at 11.1, Hispanic Latinos at 24.8, and a range of 28.3 for Dominicans and a low of 14.9 for South Americans. Now, as we switch to leading causes of death on the right-hand side of the slide, you can see non-Hispanic whites on the left and Hispanics on the right. And here you can see that in terms of the top 10 leading causes of death, the first two are cancer and heart disease. And then in both Hispanics and non-Hispanic whites, they account for two in every 5 deaths. But you can notice that they're flipped. For non-Hispanic whites, heart disease is number 1, whereas Hispanics, it's cancer. And it used to be the same. Hispanics used to have cancer as number 2, but probably about 13 years ago, that flipped. And we're going to talk a little bit about why that might be. Hispanic death rates for 7 of the 10 leading causes of death were lower for non-Hispanic whites. And we had similar death rates for kidney disease. The only 2 conditions where Hispanic death rates were higher than that for non-Hispanic whites was diabetes and chronic liver disease. So if we then look at some differences by Hispanic subgroups, we look at all-cause mean age-adjusted death rates, we can see that Hispanics had a 24% lower mortality rate compared to non-Hispanic whites. So looking at the top 2 rows. Then when you compare by Hispanic subgroup, for those that we could do this comparison, we were able to see that Mexicans and Cubans on average were much lower than non-Hispanic whites, but Puerto Ricans were very similar in terms of their mean adjusted death rate at 703 compared to 746. Also, we looked at the mean age-adjusted death rates for cancer and heart disease, with heart disease in red and cancer in blue. And so we can see here that both heart disease and cancer were lower for non-Hispanic whites. But once again, when you look at subgroups among Hispanics, for those that we could look at this, we see that Puerto Ricans were similar to white non-Hispanics, very similar for heart disease. And although not quite as high for cancer, Puerto Ricans also had higher cancer rates compared to Mexicans and Cubans. And what about mean adjusted death rates for diabetes and chronic liver disease? Those were the 2 conditions that we know that Hispanics had higher rates of death for those 2 conditions. So here we can see that Hispanics had about 50% greater death rates for both diabetes and chronic liver disease, with Mexicans and Puerto Ricans having very similar high diabetes rates compared to Cubans, and with Mexicans having the highest chronic liver disease and cirrhosis rates. And what about disease prevalence and healthcare utilizations? We saw that Hispanics had lower self-reported prevalences of cancer, heart disease, and smoking, but higher prevalences of diabetes and obesity. They were also less likely to report having had recommended colorectal cancer screening. And Hispanic women were also less likely to report having had recommended screening for breast cancer and cervical cancer. And then if we look at the differences between Hispanic subgroups for some of these conditions, so for example, prevalence of current cigarette smoking among Hispanics, we can see that overall Hispanics were on average 57% as likely as non-Hispanic whites to report cigarette smokers. So much less likely. However, you can see that when you break it down by Hispanic subgroups, you can see that Puerto Ricans had almost quite similar rates, statistically speaking. They were identical to white non-Hispanics. Cubans also overlapped with Puerto Ricans, and Central and South Americans were much lower than either Puerto Ricans or Cubans. The prevalence who had lack of health insurance, we can see that overall Hispanics were on average nearly 3 times as likely to report lack of health insurance compared to non-Hispanic whites. But once again, we can see there's a spread there between Central and South Americans at 45.8% versus Puerto Ricans at 20.7%. And then also we looked at prevalences by place of birth. So we can see US born in blue and foreign born in orange. And for every single outcome we look at here for cancer, heart disease, obesity, cigarette smoking, US born had a higher prevalence of cancer, heart disease, obesity, and cigarette smoking compared to foreign born Hispanics. So in general, there seems to be a better health outlook for all Hispanics combined compared with non-Hispanic whites, despite many social factors, and that's been termed the Hispanic paradox. And there's a number of hypotheses that might help explain this paradox. One is that Hispanics have lower smoking rates overall, so that has a lot to do with it. Migration to the US of healthy immigrants, as opposed to those that are sickly, and then also reverse migration of elderly or sick Hispanics. So, you know, as you get older, it's possible that you go back to your home country to be with family who will take care of you, et cetera. And so your deaths or your illnesses at an elderly age are not represented in the national statistics. And also that there may be sort of an interrelationship between a number of these findings. So for example, there's elevated death rates from diabetes and chronic liver disease. And we think that that has a lot to do with the fact that Hispanics have elevated obesity prevalence. And also obesity has also been linked to cancer. You know, the morphology of fat cells over time, the enlargement of those fat cells has been linked to cancer. And so also finally, that there are some potential causes of these elevated deaths from chronic liver disease and cirrhosis in Hispanics. And these include higher deaths from lower vaccination for hepatitis B, higher prevalence of binge drinking and alcohol. So although Hispanics have a lower prevalence overall of smoking and drinking, whenever they sit to drink, they tend to drink more. So that's considered binge drinking. That can have adverse effects on your liver that are irreversible. Also higher levels of obesity. And then there's an idea that if folks aren't able to read labels on medication bottles, like over-the-counter medications that can cause liver damage, people might accidentally overdose on those medications. So in conclusion, there's important considerations in decreasing the leading causes of death in Hispanics, and those include social determinants and in infectious disease etiologies. There's a need for feasible and systematic data collection strategy to reflect the health diversity in major Hispanic origin subpopulations, including by nativity. There's a need for culturally and linguistically appropriate healthcare and preventive services for Hispanics, and a need for increased outreach to both decrease the proportion of uninsured Hispanics and to educate insured Hispanics how to best utilize their insurance. And finally, there's a need for a patient-centered medical homes to ensure use of key services among Hispanics. And so just wanted to acknowledge my co-authors, and then also alert folks who are interested in doing an internship at CDC that there's a website where you can go to called www.cdc.gov/fellowships. It provides information by your educational level. And just wanted to highlight the EPI elective program for medical students. That's a 6 to 8 week elective, and you can learn more about it by going to the website there. And also postgraduate, the Epidemic Intelligence Service, the EIS program, 2-year training program for postgraduates. This is basically what brought me to CDC in the first place as well. So thank you so much for giving us the opportunity to share this information. And now I would like to introduce our next speaker. JP, do you want to go ahead and introduce?
Sure. Thank you, Dr. Dominguez. Our next distinguished speaker is Dr. Francisco Moreno. Francisco?
Thank you very much for the opportunity to be here with everybody. Thanks to those of you that are sharing part of your day here with us today. I'm going to share some slides so that I can continue with the conversation. Great introduction also by Dr. Sanchez, and a very nice overview by Dr. Dominguez about the general health issues of relevance in the Latinx or Hispanic community. And now I'll share with you some mental health considerations. When we talk about the Latinx community, I know we all refer to ourselves or to our group in a variety of different ways. So I don't mean to share how we want to call ourselves. If you ask the Pew Research Center, they will tell you that less than half of the people prefer Latino, Latina, Latinx terms, and less than half prefer Hispanic, and many of us identify with the group of origin, and gradually becoming more and more comfortable with pan-ethnic terms. So without getting caught up in the terms, as we discuss the topic here, I'll be speaking about this community. Dr. Dominguez also had an opportunity to introduce the social determinants of health. And those are conditions in which we live and are born and play and work and die that have an impact in health. But this ones listed here are those that have really shown very convincing or even very strong evidence of impacting mental health. So again, we have to continue to be mindful of this issue because our Hispanic Latinx community is particularly affected by a number of these issues. As it was mentioned, we have a lot less, being a heterogeneous group, in the aggregate, we have lower socioeconomic, more socioeconomic factors, more trouble with education, literacy, and of course, poverty, food insecurity issues, gender inequity, and racial trauma. A very important thing to be keeping in mind. Just those additive effects of microaggressions and sort of incorporations of stereotype threat issues or whatnot really affect the population that we serve in a way that makes them more vulnerable for physical and mental health issues. And we must be also mindful as providers of care and promoters of health in this community that we address and approach this population with a trauma-informed approach in mind. A couple of things to discuss. It was mentioned that about 30% or so of Hispanics, Latinx in the United States are coming from another country. They're immigrants. And this is less than 10 years ago, where it was 10% or so larger. It continues to be an important issue. And for those that have been brought up with their parents, this becomes also very important in the sense of recognizing what are some of the factors of that migration experience of the individual that came in, or that what stories we keep hearing from our parents, as these effects are not only impactful for the individual, but they may also have effects in the next generation and subsequent generations. A couple of important things to mention here. When people come to this country, there's some risk factors that they had with them and may bring with them that makes you maybe anticipate that they may be more likely to be affected in their mental health or physical health. Perhaps you came out to this country because you were not quite advancing as much in your place, and you're looking for an opportunity to even up the playing field. The immigration experience is very traumatic for a lot of people, particularly for women and children. The adaptation process then gets halted because of a lot of different issues. I'm not going to go through the whole list, But needless to say, there are a lot of challenges in our ability to integrate as included members of a new, larger community. Sometimes we're vulnerable for a variety of reasons. There's a lot of fear. There's a lot of impotence that individuals may go through. And there's a lot of role transitions that we have as individuals, as family members, as society members as well. So the adaptation process can be very challenging and stressful. However, individuals that are coming in, having lived through a lot of these factors that can be very, very stressful, actually tend to do better than US residents or people that are second or third generation Americans that have come from those same sending communities. And this is something that has been replicated not only in the Hispanic community, so the Hispanic paradox that Dr. Dominguez was alluding to, also replicated in a number of other immigrant sending communities as well. So the context of the migration could also be very impactful, as we mentioned, and those that have come from very traumatic experiences, as we're seeing currently in folks that are coming from Central America. We are working with a number of individuals that are having a lot of mental health issues, a lot of trauma-related stress, a lot of depression, anxiety, post-traumatic stress disorder. Interestingly, these communities also do not have an increased rate of substance use disorders or tobacco use. And one may, hearing a lot of the political rhetoric and concerns that people share, the Hispanic community tends to underutilize substances, alcohol, legal and illegal drugs compared to other communities, especially the immigrant community, different to folks that have been here for more generations. So what are some of those protective factors that people have with them, and how can we leverage those to make sure that we advance the protective effects that some of these communities have with them? And this is something that is consistent with the literature in other indigenous communities that has been shared from New Zealand and Native American communities, other Amerindian communities, and folks in Asia and Africa as well. The preservation of identity becomes a very important piece. And keeping some of those values that you're bringing with you in the Hispanic community, that family unit and support could be also very helpful. Having advice, support, guidance from elders, and being sort of involved with one's own faith or the faith communities that could be also an extended source of support. And so these kinds of issues that are an important challenge, because as you're moving to a new country, a place in which your role and what you mean and what you represent may be very different to what you had in your country of origin or your culture of origin, represents a source of tension. And being able to navigate through that healthy acculturation process is something that must be done at a pace and with a structure of support that allows us to healthily move into these new countries as well. Importantly to say, Dr. Dominguez has shared a lot of data on risk factors and health outcomes. If we look at serious psychological distress as measured epidemiologically, we see Hispanics here in this column, the fourth column, which is the fourth column across the various graph. And what you see is, the American Indian and Alaskan communities observing more psychological distress compared to African American and Hispanics. But as you see going through some of the negative outcomes, such as suicide, there seems to be a bit of a protective effect also in the Hispanic community. However, also when it comes to accessing care, and receiving adequate care, we see that a lot of the underrepresented minoritized groups are a lot less likely to receive mental health treatment, including pharmacological interventions. A couple of points to bring up, how come? We had spoken about cost issues, less insurance for the Hispanic Latinx community, less availability and awareness of mental health services for them, less ability to get to those places where you can get the care. There's less specialists. And the quality of care history has also something that is going to keep people from coming back and asking for the kind of help. We have spoken about linguistically and congruent care for individuals as a very important priority. We know from studies that when you're speaking with folks that do not speak your language, particularly in psychiatry, it's difficult to establish a rapport, to share more information, but also to be understood by the providers. We get different care that is not as good. There's a lot of stigma and shame in a lot of immigrant communities, definitely the Hispanic communities, that remains an important issue. I shared about the limited English proficiency, the importance of supporting programs through LMSA and other groups in which we have an opportunity to really be able to train folks in Spanish and learn to be culturally proficient. And for those that are not, don't have the opportunity to know the language, how do we utilize the resources that can allow us to best serve this community? How do we work with interpreters, with brokers of knowledge? And how do we support programs without really stratifying care to make sure that we design kind of culturally affirming approaches that are going to be supporting those protective factors that people have? I shared briefly about trauma and how serious of an issue it is. We don't really have time to get into the models of trauma-informed care, but it's a very important piece. I just wanted to put the thought in people's mind about exploring a little bit more about what we mean by trauma-informed care. How do we not mandate or tell people or come across as dictatorial experts, but rather partner and empower the individuals to be able to collaborate as equal partners. I don't think we have enough time to really get into coronavirus type conversations, but I just wanted to say a couple of things. The Latinx community has been affected more frequently. They have more complications, more hospitalizations, and more death. And there's a number of variables, many of us have heard about them, that are risk factors determining this particular risks, something we must really do something about. And I think I'm gonna stop there so that we can have an opportunity to really have more questions here in a bit.
Thank you very much to our panelists. And Cristina, could you please set now the patient testimonial, Michael's story?
Hi, my name is Michael. This is my personal experience. So in 2017, 2 months before my undergrad graduation, I went from being a pre-medical student to a patient due to my unexpected chronic renal failure. As I became ill and I became a patient, I realized the huge health disparities within the community and the Latinx community. Throughout my whole journey and learning about my situation, the first thing that came to my mind, the word money. Where would I get all the money for my kidney transplant? Being from a single household, I had the responsibility to contribute financially throughout my entire life. Being sick and being unable to work the regular hours that I normally would work, I had an extra burden, mainly because I had this internal war within myself where I had to really think about how would I not only keep contributing to the financial income within my household, but also how would I get the money to help those hospital bills, which everybody knows is a huge burden that everybody experiences within my Latinx community. I believe that this was a huge turning point for me and myself. I realized that I had never taken care of myself, mainly due to, again, my financial situation, which impeded me from going to my daily doctors or my daily visits to actually check what was happening within my body. And I believe this was one of the key factors that ended up increasing the risk factor of my renal failure. Throughout my dialysis treatment and all the way to my kidney transplant, I realized another factor, which was the lack of diversity within the healthcare. I realized that as a patient, I wanted to have that sense of trust with my doctors, but I realized that I couldn't have that. So that overall gave me a sense of distress because I couldn't actually express myself to him and become vulnerable to him because I was just being treated by someone who was a stranger to me, someone that couldn't really relate to what I was experiencing or my social background. I realized that language barrier is still a huge gap within the healthcare. Despite being a college graduate, I still had trouble having that sense of ability to understand certain medical terminology that would enable me to understand my illness and what exactly happened to me. And I feel that eventually created this self of insecurity and not being able to show my full vulnerability to another person. As a patient, I experienced those barriers that contribute to the health disparities within the Latinx community. Overall, when it comes to health disparities, we must include the factors such as being culturally sensitive, socially aware, and the ability to show a sense of social empathy. The ability to understand that everybody should have the same treatment despite their socioeconomic status, their language is crucial for the overall health system within our community and the Latinx community.
Thank you very much. That was quite powerful. Now, this is the time where we can have the audience ask questions. Christina, do they have the possibility to unmute themselves and ask questions, or they have to type them in the chat?
Both are options. However, typing it in the Q&A would be the easiest option.
All right. So we are having here some questions already coming in. All right. So Dr. Elvie is asking, how do we get more Latinx individuals in healthcare and in academics so that we can reduce some of these disparities? If any of the panelists would answer that, please.
JP, I think you're muted.
Yeah.
Do you want to have at it, or do you want to get started?
Yeah, I could take a quick comment on this. I am a proud product of pipeline and pathway programs. I think that pipeline and pathway programs as early as possible, even as early as elementary school, are critical for individuals who have not been given the same access to educational opportunities or professional development opportunities. And I think in particular for the community that we're referring to today, Hispanic Latinx, it's not only about supporting them in their educational attainment, but in recognizing the cultural capital that they bring and tying that into the pipeline and pathway programs. So it's not only about supporting their ability to succeed at standardized exams, but what does it mean to nurture their bilingual identity? What does it mean to be a Chicano, Guatemalan, Puerto Rican individual growing up in either an urban or rural environment? What are those lived experiences? And how do we nurture an awareness and appreciation of those lived experiences so that they could be that diverse talent that we need within our academic health centers? That has not been done historically. I think we need to consider those elements. And let me just say that I am here in front of you because the first medical epidemiologist that I met was Dr. Dominguez, but that didn't happen until I was already at the latter part of college. So it took doing a program that I applied to on my own in my senior year of college before I came to the decision that we needed to have Hispanic Latino medical epidemiologists. So I thank him for his continued mentorship. Thank you.
And I don't want to make our answers too long, but I want to say that JP also leads BNGAP, the Bringing the Next Generation of Academic Physicians. And the role of that organization is really to support pre-faculty individuals from underrepresented backgrounds with an important focus on Hispanic Latinos as well, Latinas, to promote their interest and facilitate their success in academic medicine as well.
Thank you. We have a question from Mary Carmen. She asks, how do you properly recommend a Latinx to see a mental health professional when they are very resistant?
Excellent questions. As we mentioned, we have a lot of concerns with bias and with stigma in the Latinx community. That is getting better. We must talk about it. We must continue to educate folks. A lot of folks who are from Latinx Hispanic background do not recognize the fact that they're actually having mental health issues. They will go and see a neurologist or a primary care or somebody else outside of the psychiatric community to do that. Sometimes it's looking at clergy and other folks because it becomes even easier to talk to anybody that is not a psychiatrist or a psychologist. The truth is people do listen. And if we share with them, rather than a demand for them to do something because it's their fault, but rather normalize the fact that we are living through this issue, the needs that we have and how what people have to offer could be really helpful, that there's a lot of evidence of benefit and that it's not a weakness, and try to reassure folks of the usual kind of barriers that impede their acceptance of this. It could be one way of getting folks to want to be part of this. And we approach this also in the Latinx community as a family. So we very frequently, in my practice, I would have 2-3 people in the room, not just the patient. If somebody else calls to make the appointment, we'll make the appointment. It's not like, oh no, the patient needs to call us. It's you know, oh, the patient is over 18 or the patient is you know, an older adult. No, we can do that, and we can bring people in, of course, with the approval of the person. We do this in a way that is congruent to how they do the rest of their lives, not the psychiatry way or not the Occidental way.
Thank you. Alfonso asks, is there any research on the effects of COVID-19 in relationship with early interventions, screening, detection in children with autism spectrum disorder, deafness, vision screenings, etc., at the national level, state level, or county level that you are aware?
This is Dr. Dominguez. I know that there are some national pediatric studies that are going on, specifically whether they're looking at, you know, detecting sort of some of these issues in children early on, and whether that might be related to COVID-19. I'm not sure, but it could be. We can try and get more information to you after the session, though. Thank you.
Is there more questions of the audience? While they come, I think it's really a very interesting question to ask you guys. If this problem with diabetes and obesity in the Hispanic Latinx community, there is always this discussion whether it's genetics or is it the McDonald's effect. So what do you think?
This is Ken Dominguez. I think it has a lot to do with the situations in which people find themselves. So I think that, so for example, with adults, we know that early on, when people first come to the United States, they have lower rates of obesity, et cetera. But as time goes on, they take on multiple jobs to be able to pay for housing and food and all that sort of thing. So they have less time to exercise and to be out in the community and being active. So over time, they become more obese and they take on the characteristics of the general population. So I think, unfortunately, based on the type of society that we live in, it's not conducive to, for Latinos in particular, to not have obesity. So I think that's something that we need to work with. There's a number of culturally appropriate recommendations in terms of portion control and how to explain portion control to folks. Also, there's issues around food deserts, living in urban areas where there's no, the likelihood of having a vegetable garden in your neighborhood or that sort of thing. Also, the way that supermarkets are organized, they tend to have sugary foods up the front, and people tend to buy what's close, what's readily accessible to them when they first enter the store, especially if they have them on sale. So it's important for people to work with their local grocers and say, hey, look, we want the green items up front, the fruits and vegetables up front, so that we're more likely to purchase those items. So I think it's a combination of very many different things, but I think social determinants play an important role in obesity in Latinos here in the United States.
Thank you. There's a question of Dr. Elliott. Why are there no women represented in this panel? Well, that's a good question and something that we should learn from this. Thank you, Liz, for bringing that question. Laura is asking for Dr. Moreno, thank you for your presentation. As a psychiatrist, what do you recommend we as developing health professionals share with our familia y comunidad experiencing more anxiety and depression during this time of COVID-19 and social distancing, especially those of us from family-oriented groups like Latinx during this time of COVID, where familia visiting, going to church or support groups, and more had been limited, possibly contributing to COVID-19 fatigue?
Yes, very good, very important question. Unfortunately, that was the next slide that I didn't get to. And in the interest of time, I'll just mention a couple of important things. Recognizing the importance to intentionally addressing mental health is fundamental. We take it as a given. And if we don't have mental health, it's like, what happened, right? We worry many times about watching our weight or exercising or doing something else, which can have an effect on mental health, but we don't do it thinking of our mental health. We do it thinking of something else. So incorporating that sort of effort to do that, I think, is going to be very important. Ways of avoiding this fatigue, I always tell people, manage your information, balance meeting your safety and basic needs. When we're on TikTok or Facebook or whatever you spend your time watching or liking, you're going to be getting more and more of that. And we get polarized information and criticism of people that are doing something else. And now we're politicizing COVID and other social determinants of health, which becomes a major issue. We know we're tense, so we have to do our best to minimize the tensions. Give ourselves space whenever it's possible to do that. I always tell people, be aware that during these times, there's more child abuse, more domestic violence, more drinking, and more sort of comfort eating. Let's do something about it. Be mindful, make sure you're at your nicest. That not only we are not going to hit somebody, but we're going to do our best to show the love and support that we all need during these very difficult times. Physical distancing is becoming a challenge. People are getting tired. They're kind of getting together. We have to keep promoting physical distancing and advancing social proximity with the family, with the church communities or whatnot. Again, it's not okay to be going back to big conglomerations of large groups of folks. But again, doing all of that is important. And if you recognize that you need help, find it. It's available and it's affordable and it's there in your language. We need more help, of course. We need a lot of sources of addressing the needs of people, but the help is there. And we need to make sure that we don't leave that for later, for after the pandemic, because there's this is something we have to address with a sense of urgency.
All right. Well, we run out of time, but we have still a question that I'll make sure we'll make sure to provide it to the panelists. Thank you very much, everybody. I think if I can speak for the general audience, I think we are more learned now, more aware, but especially more intrigued. There are many very interesting questions that arouse from your presentations and that make us think, and we are in a complicated society, and we have all to put our best efforts together to try to make the best situations for our communities. Thank you very much again.
Hector, if I may, on behalf of Chicago Medical School, I'd like to take this opportunity again to thank our three presenters. You all have done a wonderful job of informing us today and raising our awareness, and we hope to continue these conversations in the future. Once again, congratulations as well to the Office of Excellence in Diversity and Inclusion for putting on this session, and we hope to have many more such sessions in the future. My thanks also to the participants who joined us today. And Christina, thank you for recording the session so that those who did not or were not able to will be able to view it in the future. Thank you very much. Have a wonderful day. Bye-bye.
Thank you, the